thank you all so much for joining our flash talks for today. We have a really amazing lineup, and let me see. Oh, we only lost a couple of minutes, so I think we are definitely okay. So our topic for today is digital mental health services for marginalized communities. And let me just orient myself a little bit. I can see that people are still coming in. So let me see if our first speaker is here. Yes, Jessie Gibson is here. Wonderful. Well, then I will invite you to share your screen, Jessie. Just with that, yeah, just go ahead and share your screen. We can't see it yet. There you are. Wonderful. So Jessie, and when you are ready, feel free to kick it off with our first talk for today. And just to orient everybody, so we have about 4 minutes or so for you to talk, right? And then we hope that we can engage the audience a little bit and can have a few questions before we move on to the next speaker. So go ahead, Jessie.
Great, thank you. So I will be talking about advancing access to psychosocial anxiety treatment in neurodegenerative movement disorders via web-based interpretation bias training. I'm an assistant professor of nursing at University of Virginia, and my collaborators here are Jeremy Eberle, Alex Werntz, and Bethany Teachman. I would like to acknowledge our funders. I do not have any relevant disclosures, and also some of our other collaborators named here. So Huntington's disease and Parkinson's disease are neurodegenerative diseases that are characterized by motor, cognitive, and neuropsychiatric decline. Both are typically most recognized for their motor symptoms, chorea and Huntington's disease, and tremor and Parkinson's disease. And both begin with degeneration in striatal neurons and surrounding areas. Huntington's disease is an autosomal dominant disease. So each child of a Huntington's parent has a 50% chance of getting the disease. And it's a pretty rare disease, whereas Parkinson's is the second most common neurodegenerative disease after Alzheimer's. And the age of onset is in adulthood for both of these. So anxiety is very common in these diseases, although the motor symptoms tend to be tend to get the most focus in research and clinical treatment. And this is a problem because anxiety can really affect quality of life for patients and caregivers. So some of the prevalence estimates have been up to 71% of people with Huntington's disease and 68% of people with Parkinson's. This is also a problem because the medications we currently have are limited by off-target effects. They can interact with other medications used for Huntington's and Parkinson's, and side effects can also worsen other symptoms of these diseases. So as a result, experts recommend psychological intervention for anxiety in these populations, but the typically recommended interventions, such as CBT, often lack accessibility and scalability if they're in person or psychotherapy based. Things like motor symptoms and gait instability, driving cessation, and financial limitations particularly limit access for these populations. And we found in some of our preliminary qualitative work that anxiety in HD and PD may be linked to negative interpretation biases, such as catastrophizing or social threats. So we think that cognitive bias modification for interpretation is a potentially useful intervention that could address some of the limitations I've noted. And CBMI trains participants to think more flexibly to reduce anxious thinking. So we conducted pilot studies to establish feasibility of CBMI and HD and PD. We used the MINDTRAILS program, which is an existing CBMI program led by Bethany Teachman. And these were our inclusion criteria. And here's a sample here where participants are asked to complete the word and then to resolve an ambiguous scenario and then reinforce comprehension. So just some of our preliminary findings quickly. We actually found that a lot of the dropout in our pilot studies happened before they even enrolled in the MINDTRAILS before they began session 1 of the MINDTRAILS program. And that was related to the consent in the program itself being located in different systems, and also having too many baseline surveys. So people filled out too many baseline surveys and they decided I'm too fatigued, this is too much for me, I don't want to continue. But of those who did complete all 5 sessions, or of those who did begin the first session, most did complete all 5 sessions. And some preliminary efficacy data here, we found that in Parkinson's, 9 of the 14 completers, which is 64%, showed improvement in anxiety symptoms, and 67% of the Huntington's completers showed improvement in anxiety symptoms. So most people in qualitative interviews afterwards reported a positive experience. They reported that they would recommend this program to other people with Huntington's or Parkinson's, and that it was helpful and engaging. However, they pointed out some modifications that are needed specifically for these populations. The first being that scenarios should be tailored to reflect disease experience. So this includes both symptoms associated with the disease and social concerns of people judging them because of their visible symptoms, as well as stage of life. Some of the scenarios included things about students or working adults, whereas some of our participants were retired or non-working. Shorter session length would also be helpful and make the program more accessible for people. And then they also shared some considerations for whether this would be useful as a mobile app for this population or if that would be more difficult. And another takeaway is that every person is unique. So as much as we want to tailor for a disease process, we have to keep that in mind as well. So in conclusion, we feel that cognitive bias modification for interpretation bias is feasible and acceptable in these populations, but we are planning to modify our existing program so that it's tailored to meet the needs specifically of these populations, with the ultimate goal of offering an effective, accessible psychosocial treatment option for anxious individuals with movement disorders.
A very nice presentation. Let me see if there are any questions for Jessie. I have one. You developed this really beautiful intervention, and what do you think you will do next in order to get it out in the real world? I'm just so inspired by the panel that we just had. So where do you think your work will take you next to make sure that we actually give access to people outside of research trials?
Yeah. So and I'm trying to stop sharing my screen, but having trouble doing that. The next steps in our work are to we're adapting the program now, and then we'll test it in a preliminary efficacy randomized controlled trial. And as part of that work, we are really engaging with organizations that are patient and provider facing organizations, and then also reaching out to clinicians and other people to basically try to build awareness of the program. So I agree, we think it has great potential to be disseminated because it's free. It's on the phone or the computer, so it should be easy to access. But kind of starting now with working with those advocacy organizations. And then we're also in the process of starting a community advisory board as well to get buy-in early on as we create this tailored version. And we're hopeful that they can help advise us as well on how best to disseminate.
That's great that you're also connecting the community with the communities you're trying to serve. That's wonderful. Very nice. Okay. And I see Roger is here. Roger, you are up next. Do you want to please share your screen?
Yes, I'll try. Let me see.
Yeah.
I do this right.
So Roger is going to talk to us about increasing the health equity and population level impact of a digital therapeutic for smokers with psychiatric illness. And it's, I can see it coming up. Wonderful. Take it away, Roger.
I think, I'm not sure if you can see my note screen or the other screen.
We can see, I think both, but we can see the other screen real well. So that should be all right.
Okay. All right, I'll just go ahead. So, yeah, my name is Vilardaga Viera, and I'm a associate professor at Duke University. These are my collaborators and disclosures. So, tobacco use disorder affects people with psychiatric illness quite severely. The rates of tobacco use in the U.S. have been reduced dramatically over the last 50 years, thanks to the efforts of the public health community and a lot of researchers and public and providers. However, the rates of smoking among psychiatric populations is still very high. And just to give you a figure, between 1% and 3% of the U.S. population, which has a psychiatric illness, this is an estimation, they consume 30 to 40% of all the cigarettes sold in the U.S. So that's still it's a very high priority group that we still need to make a lot of advances and progress. So as you all know, there's an important staff shortage in terms of mental health providers in the U.S. And specifically how this affects smoking cessation treatment is that mental health providers typically don't have the bandwidth to deliver smoking cessation treatment to their patients. And on the other hand, more scalable solutions like quit lines, for example, they're not acceptable. They're not patients with psychiatric illness don't feel comfortable with those mediums and those delivery systems. So we need to find alternative ways to address tobacco use in these patients. So a few years ago, I got funding for the Mind to Quit trial. This is based on a smartphone app that I developed called Learn to Quit. And the trial, what it does is it tests this digital therapeutic against breath advice, which is what typically patients would encounter in their, in day-to-day care by their psychiatrists, providers, primary care physicians, etc. This is ongoing. In parallel, we also sought feedback from the FDA to assess the possibility of implementing this device, obtaining clearance from the FDA to use this device as a prescription digital therapeutic. So we gained a lot of clarity about the design, the desirable design of this clinical trial, and how it could potentially be used in real world settings. Now, a few years ago, I published a couple of pieces where I made the case that regulatory oversight of digital therapeutics could be a very important approach to actually increase the quality and evidence-based standards of digital therapeutics, especially when it comes to vulnerable populations, patients with opioid disorder, suicidal behaviors, etc. However, I also made the case that neither the use of digital technology, which in theory is scalable, or the application of user-centered design standards, which increases usability and engagement, or even FDA clearance, will necessarily solve the systemic challenges of health inequities that already are available or existing in the field. So kind of like to give you a gist of that problem in this specific context of smoking cessation, we were wondering about what are the smoking rates of people and the intersection of multiple priority populations. And specifically, we looked at people with mental health symptoms, tobacco use disorder, and racial and ethnic minority identity. And we argued that this is a high-risk intersection. And then we used the National Survey on Tobacco Use in the U.S. is a little bit over over a decade and a little over 500,000 responders. And when we looked at the rates of smoking with just two intersections, tobacco use and racial ethnic minority, we found that Anglo Americans, Hispanic Americans, and Black African Americans had consistently reduced their smoking rates over the last 10 years. But when we added the third intersection, which is people with serious psychological distress, which is a proxy for mental illness, we found that the only group that experienced a significant decline were Anglo Americans, but not Hispanic Americans and African Americans, which had flat rates of tobacco use over the same period. So in kind of response to that, we use the Mind to Quit RCT, which is the one that I mentioned earlier, as a platform to examine those health inequities that we observed in the literature. So the plan for this is an ongoing project, the Digital Equity Project, and the plan was to use this trial to conduct qualitative interviews with former participants who were Hispanic or Black with serious mental illness, and to assess their lived experience with the digital therapeutic and try to understand barriers and facilitators. At the same time, we'll be examining or interviewing directors, administrators, and providers of mental health clinics to understand and ask similar questions about what are the barriers and facilitators of delivery of tobacco services to these patients. We also plan to conduct the program evaluation, which is a more quantitative assessment of the actual delivery of smoking cessation services among these patients. And then in the context of the ongoing trial, we added 3 new measures, which according to the REAIM model represent, effectiveness from a more holistic perspective, which is not just quitting smoking, but also quality of life factors, assessing digital divide, and we created a specific survey to assess that very thoroughly, and then experiences of racism during participation in the trial.
Just if you could wrap up within 30 seconds, that would be wonderful, so that we stay on track.
So basically, we applied a mixed methods approach to turn this clinical trial into a hybrid type 1 effectiveness implementation trial. And the idea is to generate data for a future pragmatic trial. So the bottom line is that we need to better understand barriers and facilitators that impact the adoption of digital therapeutics among patients at the intersection of multiple priority populations. And then we need to utilize the available methodological tools that we have at our disposal in academia to assess those factors. And that's all. Thank you so much for the opportunity to talk about this project.
That was really great, Roger. Thank you so much. Unfortunately, we don't have time for a question, but I just want to comment on something you just said in passing, and I thought that was just so critical, which was that even if we go through all of the steps with, working with the FDA and going through the regulatory process, it still doesn't fix all of those issues that you were just pointing out with regard to health equity. And I think this is something that is actually often overlooked, and hopefully we have an opportunity at this conference to discuss that piece a little bit more. Really nice presentation. So unfortunately, our next speaker could not be here, but sent us a video. So I'm going to try to share this with you now. Let's see if that works. Last year at the conference, we had a little bit of trouble, but you should all see a video right now, and hopefully it will play.
Talk, a digital music-based mindfulness intervention for Black Americans with elevated race-based anxiety, multiple baseline pilot study.
Do you all see this okay?
Background and some background information on race-based anxiety and mindfulness in the Black community. Race-based anxiety, i.e. anxiety that stems from experiences of racism, is a major health issue within the Black community, yet there are just 4 published studies, to my knowledge, that address this health condition for Black Americans. Treatments that cultivate mindfulness, on the other hand, which is a kind, conscious attention to the present moment, have demonstrated efficacy for anxiety in meta-analyses and systematic reviews. However, there's also 3 central barriers that often prevent Black Americans from accessing these treatments. The first is that most treatments are not culturally relevant to Black Americans. The second is that a lot of evidence-based treatments take a lot of time. And the final one is that many mindfulness-based treatments are high-cost. To address this limitation in existing mindfulness treatments, I've created Healing Attempt, which is a brief digital music-based mindfulness intervention for Black Americans. It's roughly 25 minutes long, and it combines pre-recorded and originally composed songs, guided meditations, and poems, all set to background music tracks that are informed by Black American music traditions like rhythm and blues. Additionally, the intervention features contributions from renowned Black American collaborators such as Lombard Owens, who's a meditation teacher and a leader at the intersection of race and social justice, and an LA Times bestselling author, as well as Terry Edmonds, who is a former chief speechwriter for President Clinton. And so now I'm going to tell you all about a study that I did to test, pilot test this intervention. For the study design, I used what's called a multiple baseline design, which entails taking repeated measures across time for each participant to compare an outcome of interest across 2 different phases. a baseline control period, or an A phase, where no intervention is deployed, and then a subsequent intervention period, the B phase, where an intervention is utilized. The independent variable in my study was the intervention, like I mentioned, and the dependent variable is going to be state anxiety as measured by the state-6 scale. Participants in the study are 5 Black American adults with elevated race-based anxiety, which is an online study platform with higher data quality than other platforms like Amazon and Turk. And I also conducted the study visit on Zoom to verify participant identity and engagement with the intervention. Participants were encouraged to sign up for a study visit on a day in which their anxiety was elevated. And participants were randomized to one of 5 baseline conditions that varied in length between 10 and 26 minutes of baseline. During baseline, participants went about business as usual, and then following baseline, I administered the 25-minute intervention. I assessed state anxiety every 2 minutes in my study, and then after the intervention, I assessed feasibility and acceptability with a series of quantitative questions on a scale ranging from 0, which is low feasibility, to 100, which is high feasibility. For my analyses, I used something called TAU analyses, which is a widely used analytic approach for multiple baseline studies. The benefit of this approach is that it allows one to incorporate data trends and the effect of time into one's results, which is advantageous for the study because I expected state anxiety levels to fall naturally over the course of the study, so it allowed me to incorporate any such trends into the study. TAU values typically range from -1 to 1, and the magnitude of the value is a proxy for the strength of the effect. So for instance, a TAU value of -1 for the intervention would indicate that the intervention has a strong negative effect on anxiety, so it reduced anxiety. And I also calculated mean averages for all feasibility and acceptability questions in my study. Now let's get into the results. So I want to orient you all to this table really quickly. On the first column features 4 different TAU models that I ran. The first model is just a simple A versus B phase, control phase versus intervention phase comparison. The second model, the second line, is A versus B phase controlling for natural downward trends in baseline anxiety. The third is A versus B controlling for trends in intervention, natural downward trends in anxiety during the intervention phase. And then the fourth line controls for natural downward trends in both the intervention and baseline phases. The second column features the raw TAU values. The third and fourth columns feature the confidence intervals for those values. And the final column to the right features the p-values. The key takeaway is that there's a preliminary signal here clearly that the intervention reduced state anxiety even when controlling for natural downward trends in anxiety in a myriad of ways. The next suite of results is the feasibility and acceptability of the intervention. Here you can see a host of different dimensions ranging from the likelihood of folks recommending the intervention, how helpful the intervention was for anxiety, how easy the intervention was to engage with, how much it improved the ability to be present with emotions, relationship to self, how much folks felt like it was made for them, and folks feeling like longer engagement with the intervention would be helpful. The key takeaway is that there's high feasibility and acceptability across all key metrics. So the study provides preliminary signals of feasibility and efficacy of healing attempts, and future studies can more rigorously assess the feasibility of the intervention between subjects and trials.
All right. And unfortunately, our speaker is not here, so we can't ask him any questions, but this was a really wonderful talk. And we are actually now back on time, which is great for Louisa, who's our next speaker. So Lisa, would you please put up your slides?
Oh, I was muted. Hello, everybody. Let me get to the slideshow. All right, let me keep track of my time. Okay. So this is a cozy crowd. I wish we had more time for questions and discussions, but I'm happy to share this sort of what I call a labor of love is a community-based exercise program that my colleague Anna Maria Francioni and I have been working on for the past year. So specifically, the rationale for this, and these are our 2 groups, and everybody here consented to be in this photo and to share with all of you, which is wonderful. These are our 2 sort of introductory groups who joined our exercise study. The reason we're doing this study is because people don't exercise, and particularly people who are in underserved communities, particularly ethnically and racially underserved communities. And so that was the goal of this project, was to get out into the community and get people moving. So we did some focus groups first to better understand what some of the barriers could be to creating actually an online platform to support a very established exercise program called the Fit and Strong program, which our colleagues Susan Hughes and June McDermott had developed with funding from NIA and had been doing it in the community and in Black churches as well, and had great success. The problem was that after the 8-week exercise program ended, everyone stopped exercising. So we tried to figure out how we could get people to continue to exercise after the program ended. And we thought a digital mental health intervention could be the solution. So that's what we sought to do. And we again did the focus groups to build the platform. And then we did these 2 groups where they enrolled in the, actually skip over that. They enrolled in the program. They did their baseline assessments. They started the Fit and Strong exercise program. You can see the different assessments that we used. They did 8 weeks, 3 times a week. I didn't think there was a chance in the world we'd get people to come in to do an exercise program, older adults, just after COVID, mind you, to do a 90-minute exercise program 3 days a week. But we did it. They loved it. Again, kudos to the Fit and Strong program for developing a really fun class with music. And what really happened was that people just kind of bonded, and these groups are, I think, going to be friends forever and will be supporting each other forever, which is wonderful to see. So that was the exercise program. It ended, and we actually got them started on the online platform while they were doing the in-person exercise program, because we didn't want them to sort of graduate, go off from the world and have to navigate this platform by themselves. So actually all the assessments and everything was on this platform. And I'll show you some pictures of that in a minute, but this gives sort of a layout of what we did. And I don't have many results because we just finished the last group last week. So we really have, this is really kind of a lessons learned from just doing the project. So this is the platform. On the left-hand side, you can see sort of the different aspects of the program and what you can do. The Fit and Strong participant manual is there. The questionnaire, so those are all the assessments are there. So when they're, it's sort of like a red cap, essentially, they get emailed links to do the assessments on this particular platform. They have various contracts, like things, why do you want to exercise? How are you going to maintain your exercise, or sort of exercise contracts? So when they fill them out, we put a PDF there for them to remember why they agreed to participate in this program and to keep them motivated. Down here, we had these recorded classes, which ended up being much more popular than I thought. I really didn't think people would want to go back and watch previous exercise classes, but they loved it. And I think it's in part because they love the exercise instructor. They really got attached to their exercise instructor. Then we had a forum, which I'll show you another picture of in a minute. And then this exercise log here, this was sort of our bread and butter, if you will, of like sort of tracking how participants were doing in the program. One feature, this is, I'm already getting to lessons learned, but one feature that we've heard people want is to be able to share their exercise log with other participants in the program, so they can kind of, hey, look what I did, or hey, I'm struggling, can you help me out? And kind of share how they're doing, both, I think, on both sides, when they're struggling and when they're doing well. So that was a thing that we did. And the link was here. So it was sort of like a one-stop shopping was the idea, that you'd go there. Again, we did do some of these classes happened over holidays, etc., bad weather. So we did have some Zoom classes here and there. And that's where we put the link up here for any Zoom classes. And occasionally some people would like call in if they had a doctor's appointment. And so we did have, it was mostly offered hybrid. But most people came in person. We definitely preferred coming in person. This is the exercise log in more detail. Pretty straightforward, really developed by the Fit and Strong program. We simply digitized it and put it on the platform. This is the forum. I blacked out any sort of identifying information, but you can see people sort of talking to each other. We really encouraged them to talk about what they were doing, but also just to sort of like share whatever was on their mind, because we really wanted to create a community. What we started to see that was happening and bringing people to the 3 classes a week was their connection with each other. And so we wanted to try and keep that going beyond the 8-week. And we had the good fortune of working with Drew and Susan really well, and they shared some of their lessons learned in the exercise program. So we knew peer support was going to be crucial. And you can sort of see that playing out here in the forum, just in these few things. So these are some of our lessons learned. I have to say, older adults most definitely need a lot of tech support. We almost were driving to people's homes to help them get onto Zoom. We had iPads. We didn't actually have to do that. We contemplated doing it, but it was that because they were coming into the exercise sessions, usually we could grab them there to kind of get them on the platform, get them using it. But this was, I have to say, one of the biggest hurdles. Getting them to download Zoom, use Zoom comfortably. You have another lesson learned. You have to, every single study staff member has to be able to reset a password. Originally, when we started this, we had our software engineer do it. That was a terrible idea. I'd be like emailing my software engineer, like, hey, I need to reset 5 passwords right now. You need to be able to do that quickly and easily. And we even made like a lot of like, hail 1, 2, 3. So we could be like, okay, it's hail 1, 2, 3 to, assuming the participant was okay with that. They love, again, connecting with the exercise instructors, the tips, recording the classes. I'll just highlight a few other things. We got feedback that the exercise log was actually too complicated because it had different reps and things like that. So really simplifying it. And as I already mentioned, they really want to be able to share their data with other participants, which was shocking to me because I definitely thought, the older adults might be a little bit more uncomfortable with data sharing. But what I saw was, again, once they feel comfortable, similarly with that photo that I took, the beginning of the exercise class, like, no, we don't want to take a photo. At the end, they're like, let's get a photo of all of us, share it with whoever you want to. Like, we love this class. So definitely, kind of getting that comfortability with each other and then wanting to connect, and then that being so crucial to them continuing to exercise, I think is all when we think about digital mental health interventions, at least for older adults. And I would just say older adults in general, but obviously we worked with a very racially diverse crowd, was crucial. So connecting with each other. And one thing, we created buddies during the follow-up phase so they can kind of motivate each other. And now the exercise classes ended, they've reassigned and they have their own buddy system, and they're like continuing to do, like they have new buddies. They're like, we just want to mix it up. So clearly, again, connecting and motivating each other is just crucial to keeping them exercising. And one other thing we learned is leveraging community resources. The senior centers have wonderful exercise programs. We thought we would have to keep delivering the exercise classes in the churches to get them exercising. Not the case. They've got all the schedules. The community champions have sent me the different schedules they're using. They've got a very complex exercise regime that they've set up themselves through using community resources. So it has been a blast to do this study. I have not done it alone. I've done it with a lot of people. This is Tony Pham, one of our buddies who supported. So in the follow-up phase, we had a study staff member support as the buddy supporting the participant. And this is Tony, one of our research participants, with Selma Johnson, who's our community champion. And they were buddies. And then, as I said, when the program ended, they started assigning buddies within the program to each other to support each other, which was awesome. So that's it.
Thank you so much. Really wonderful study. Any questions for Louisa?
I just have a comment, which is, this makes me think about for ongoing work. I don't know if you've thought about this, but in the Parkinson's community, there's rock steady boxing, which is kind of similar, frequent engagement. People come in to do the boxing program for exercise, but what patients say is, it's building community. They love their instructor. And so I really see that as, a next step or something to think about in the future. That could be a way to pivot.
I completely agree. Connection was so important with these folks, and speaks to, I think, all the loneliness pieces that we've seen coming out of COVID and people not feeling connected. And as we think about digital mental health interventions going forward, I think ways in which we can sort of humanize them and get people talking with each other through the technology. At least that was one of our sort of main lessons learned.
Yeah, lots of lessons learned. I hope you write up just the lessons learned in addition to your results, because it's really really wonderful to see what you got that group of people to do. So thank you so much. All right, we are at time here, and our next presenter is Li-Ying Wang. So if you could please share your slide.
Yep, I am ready to share. Can you all see my slides?
Yes, it's perfect.
Okay, all right. Let me get started. Hello, everyone. I'm Li-Ying. I'm presenting this project, which is also my dissertation. I did finish 2 weeks ago on developing this unhealthy intervention. Thank you. To enhance coping skills in mental health among MSM living with HIV in China. And I'll be presenting the preliminary steps of this study, and then the feasibility pilot is still ongoing, so I won't have much results to show for that part of the project. So some background information first. While individuals' mental health often plummets at the initial diagnosis of HIV, here's some prevalence data of common affective disorders among people living with HIV, such as depression, PTSD, suicidal ideation, are all very common among this group of individuals. And For MSM specifically, these intersecting vulnerabilities further contribute to their elevated rates of these mental health conditions. And when we look at mobile health or mHealth, this is the field of research that we are in that uses technology to improve various health outcomes. And existing literature suggests promising effects of these interventions on improving mental health outcomes among both general population as well as for people living with HIV. When I zoom in on literature in China, specifically, we found that there's a lack of mHealth interventions that focused on MSM and their mental health. And the studies we did find were mostly focused on HIV self-testing or HIV transmission risk factors. The few studies we did find on adherence or mental health actually only used very simple intervention methods like texting messages or articles delivered on WeChat to elicit behavior change, which is limited, and very few of them actually provide a theoretical basis for their intervention development. So to address this goal and improve the mental outcomes of this population, MSM and HIV in China, the project involved 3 phases or 3 studies. First of all, needs assessment, which is conducting stakeholder interviews with my community partners, which are introduced in a bit. And then second part is conducting online co-design sessions to tailor the intervention content and delivery to our community members. Then third is ongoing feasibility pilot trial. And I will briefly walk through, walk through the results of the studies. So in terms of methods, we collaborated with our community partner in Shanghai. It's called Shanghai CSWMS Center, or SCMC, as well as Shanghai CDC staff members. And through them, we were able to recruit MSM living with HIV in the community to be part of our study, and also serving on the board of consultants to advise us in terms of design the study and also design intervention materials as well. So this is the result of use assessment. It's a very overwhelming diagram, but the gist of this is we used 2 frameworks. One is coping, stress and coping theory. The other is social ecological framework to guide our interview as well as data analysis. So the yellow boxes represent individual to structural level stress. The green boxes are individual coping strategies and resources, as well as resources at upper level to assist individual coping. And blue boxes represents coping or adjustment outcomes for these individuals. And we found stress from multiple levels interacted with each other and produced compounded effects on their psychological struggles among MSM with HIV, especially in the collective culture in China. So based off of this results, we determined our goals for intervention, which are across 3 levels. At individual level, we want to improve their mental health by teaching them coping skills, especially around difficult emotion and distress at the time of diagnosis. And second, at a personal level, we want to create an environment for peer support and peer learning. And third, at community level, we want to increase community capacity around mental health resources. So based off of our intervention goals, this is our intervention structure. It includes 3 components. First, individual skills training or skills learning via app, then staff-led skills groups, and third component is behavioral coaching by our community staff. Mm-hmm. So for individual component, for those of you who are in clinical psychology or know of DBT, the content are drawn from DBT skills training manual. And the reason we chose this is, first of all, DBT skills training as a standalone intervention has demonstrated effectiveness on a range of psychopathology characterized by emotion dysregulation. And second, DBT skills are organized into 4 modules, as you can see here. This offers a clear guide and allows the flexibility for me, for the researchers, to select a combination of skills to cater towards individual needs and goals. Specifically for my purpose of this intervention, distress tolerance and emotion regulation modules fit very well with our goal and our purpose. So hence we pull a lot of the skills content from these 2 modules of DBT. Okay, so skipping a lot of the details of development, jumping to the end product, sort of, which is end testing right now. So this is our app. It has 5 modules. The content is delivered in the form of podcasts, each 10-15 minutes long, coupled with an outline at the bottom and quiz questions follow the podcast to help them consolidate their understanding of the concepts, and individual would complete these modules over the course of 4 weeks of intermission period. And these are the other two additional features of this app. One is depression tracking. So individual will fill out a survey every week, and then over the course of a few weeks, they'll see a line chart in the end to report their progress over time. And medication tracking is a calendar page where they click into it and record the medication every day. And over time, they will be able to see a bar graph to reflect their adherence level over the past few weeks or months. So that's the first component. Second component is staff-led skills groups. So this happens once a week for 4 weeks. Both staff and group members were introduced the group guidelines to create this safe and constructive peer learning environment for everyone. So every week, individual would first complete podcasts and then attend the group. So therefore, the content of the skills group is actually parallel to their individual learning through the app. So this group serves the function of skills teaching, also a safe and supporting environment for peer learning and connect with the community members as well. The reason we love the group format is also similar to what the previous speaker mentioned, is that it has a community focus, focus on connection, and it touches all 3 levels of our intervention goals from individual, interpersonal, and community level. The third component of this intervention is option for the study participants, but is served as a flexible component for those who actually need more or extra support outside of the group or individual learning through the app. So behavioral coaching is where we offer, or our staff offer, additional help when individual need skillful behavioral coaching at the moment of distress to know how to problem solve a situation or how to respond adaptively or effectively to an emotional situation. So yeah, that's the intervention overall overview. And then right now the feasibility pilot is ongoing to test the initial feasibility, efficacy of this intervention. So this is the construct diagram. It's a very tiny font, but on the left side, we recruit study participants. Our aim is to recruit 29 participants, or 30 actually, and then half randomized control, half randomized intervention group, and each person randomized intervention group would be randomized into different online groups facilitated by our SAMC staff members. And then on the other hand, we also recruited SAMC staff members and then trained them. And then each of them would be leading or are already leading skills learning groups as of right now. Yeah. Okay. So that's our study design. We are collecting different, or mostly just feasibility data because it's a feasibility pilot trial. So first of all, a lot of the recruitment rates, retention rates, and feasibility acceptability, qualitative data through interview. And then second is these intervention outcomes, preliminary outcomes, including mental health, quality of life, adherence outcomes, as well as potential mechanism of change. For example, coping self-efficacy, emotion regulation difficulties, etc. Yeah, so I don't have much data to show right now. What I can say is the initial qualitative interview suggested that this intervention has a relatively high acceptability, feasibility. At the same time, one comment we received from the participants is that they really enjoyed our podcast. At the same time, like similar to previous speakers, they want this content to be further tailored to their context or their personal experience, which is challenging. And there's also something that we're excited to explore more to improve the feasibility of this intervention for these community members. Yeah, so with that, I'm going to acknowledge contribution of all of these team members, funding sources, and thank you everyone for listening to the talk.
Thank you for your wonderful talk. We have time for one question. Does anybody have a question for our speaker today?
I was going to ask, what are the rates of HIV in China? Done some work on HIV here in the US, but just curious.
Yeah, so among MSM, the trend is continuing to going up, but for the past 10 decades is relative around 10%. So like if you look into subpopulation, of course, different socioeconomic status or different ethnicity, whatever, different diversity factors, you can see the numbers would change, but the numbers would be around the range of 6-7% to 14-50% around this range.
Of the China population?
Yes, within MSM living with HIV in China. MSM population.
7%?
Yeah.
My goodness.
Of men who have sex with men, right?
Yeah, not overall population.
Not the overall population, but
oh, I see.
sex
I
with
see.
men.
Okay.
Yeah.
Okay.
Yeah.
Okay.
Yeah.
Yeah, it might be worth looking at tobacco use, because at least in the US, tobacco use is extremely high. It's up to 44% among patients living with HIV. That could be an interesting secondary outcome to look at, because that, you know, affects their health. People with HIV is more likely to die because of smoking in the US than because of HIV itself.
Yeah, we did see a lot of substance use behaviors from the interview when their emotion gets too intense and they are trying to find ways to cope. Substance use, like smoking or alcohol use, was a very commonly cited behavioral coping strategy.
So we are at time, so I wanted to thank all of our wonderful presenters. You're all tackling these really serious issues, and you're doing this in such thoughtful ways. I mean, the products that were displayed today were just really incredible, even though some of them are still in the early stages. And I was very impressed with how you thought about how to make these tools engaging, and not just in the moment, but also long term. I think everybody had at the beginning already thought about, you know, how can I sustain this when this is being rolled out in the real world. I loved all of these different ideas of how you were supporting your tools with peers at times as well. So very impressive work. And I very much look forward to next year's conference, when I know many of these projects will be a little bit further along and we can actually see how you did in your next phases, whatever they might be, RCTs or actual rollouts. So thank you so much. And now you have a little bit of a break, about 15 minutes or so. Yeah. And then what do we have next? Oh, yeah. Then we have the Ask Me Anything sessions again, which start at 1:10. So you have a little bit of a break, and then I hope to see you all in the AMA session. So thank you. Bye-bye.
Thank you all. Bye-bye.